Well, they say you cannot review what you never knew, but you knew it, so now let's review. I like to review it, view it. You like to review it, view it. We'd like to review it. I'm bleeding excessively after a dental extraction. I got a high PTT. Oh, automatically. Did you take some aspirin too, my friend? Did you show up at the age of 41 suddenly with hemophilia A and B? I don't think so. Factor 12, 11, 8, 9, 8, 9, 8, 9, 11, 12, all elevate the PTT, but factor 12 never makes you bleed. Factor 8 showing up at the age of 41, I don't think so, plus it's the wrong type of bleeding. This is platelet type of bleeding, a platelet type of bleeding, a platelet type of bleeding. Oh, but after I mix 50-50, the PTT is still elevated. Von Willie? Dysfibrinogenemia, which are very common, by the way. If you take all the different dysfibrinogenemias, they're actually one of the most common, but that would give an elevation of both PT and PTT. Factor 8 deficiency, if it was a deficiency, it would correct to normal. The other thing is, if it was factor 8 deficiency, it would be deep bleeding to the muscles in the joint, and the joint in the muscle, and the muscle in the joint, and the joint in the muscle. Same answer with factor 11 deficiency, but factor 11 deficiency would only be under conditions of severe trauma, something bad. But if it was a deficiency, bad I mean like big surgery, if it was deficiency, it would correct to normal. There's no mix, there's no correction with the mix. If there's no correction with the mix, there's got to be an antibody in there. Because it's mucosal type of bleeding, it's von Willebrand's disease. Which of these is Dick? Sorry, I meant to say DIC. Why don't we say... My God, you've got a big case of... Okay, DIC. So, what do you see in all of these? The PT and the PTT is high in both of them. The platelets are low in both of them. All of them. But what happens in DIC? You consume. Chop, 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 chop. All the fibrin split products are consumed. The fibrinogen is turned to fibrin split products and D-dimers. Fibrin split products and D-dimers. Fibrinogen is consumed and turned into fibrin split products and D-dimers. Oh, what is it? It's a shitty cell. I mean, a schistocyte. It's a schistocyte, a helmet cell, and a fragmented cells. Which of these causes schistocytes and helmet cells and fragmented cells? Folic acid deficiency doesn't break up your cells. Folic acid deficiency would give you macro-ovalycytes and hypersegmented neutrophils. Uremia gives you dysfunctional platelets. Uremia can also cause Burr cells, buremia. This is DIC. It could be DIC-TTP or hemolytic uremic syndrome. DIC-TTP or hemolytic uremic syndrome. Autoimmune hemolysis, the IgG is destroying the cells inside the spleen, so you wouldn't see it if it was IgG mediated because it's damaging it inside the spleen. Now, man is on Coumadin for atrial fibrillation. He's got multiple episodes of hematemesis. The INR is really high. Now, in this case, how do I know I need a fast intervention? Because the person's bleeding. Vitamin K automatically is out. Vitamin K is automatically out. Vitamin K is automatically out because the person's bleeding and vitamin K is much too slow. So vitamin K is out, whether it's oral or subcutaneously. Protamine sulfate is to reverse heparin. Protamine sulfate reverses heparin. So that's out. We very rarely, if ever, use that because we don't use a lot of IV heparin anymore, and it has such a short half-life anyway. But protamine sulfate would be with heparin when you have to reverse it instantly. A couple of years ago, the answer would have been fresh frozen plasma. The answer is prothrombin complex concentrate because fresh frozen plasma has a lot of volume. Fresh frozen plasma has to be defrosted. Fresh frozen plasma gives you other things you don't need. You don't need the fibrinogen. We give prothrombin complex concentrate because that's factors 2, 7, 9, and 10. 2, 7, 9, and 10 in the prothrombin complex concentrate. PCC, it basically replaces everything that warfarin inhibits. The other thing is it has much less volume, so you don't have to volume overload people. Number 3, it can be stored at room temperature. Next, fresh frozen plasma. Does fresh frozen plasma have to be blood type specific? Fresh frozen plasma. And the answer is it does. A lot of people don't know that. Because if you take your unit of FFP from a person with blood group A, there's antibodies against blood group B in there. So it has to be blood type specific. Fresh frozen plasma. So a patient comes in with a massive bleeding, requires multiple transfusions. And as you know that multiple transfusions have an anticoagulant that binds, citrate binds calcium. Citrate binds calcium, so it's an anticoagulant that binds calcium in it. And that's why after you give 4 or 6 units of transfusion in massive transfusion protocols, when you have massive transfusions, you automatically just give calcium. Patient in a pre-op evaluation has an elevated PT, but the PT is normal. Now, it corrects, so it has to be a deficiency. It corrects, so it has to be a deficiency. You mix 50-50 with normal, it corrects because we have to be missing 70 or 80% of clotting factor before it even begins to go up. Before the PT or PTT even begins to go up, we have to have 70 or 80% of clotting factor missing. So it can't be factors 2, 7, 9, and 10. Well, if it's 2, 7, 9, and 10, well, that doesn't say 2, 7, 9, and 10. That says 8, 9. Ooh. I don't know. 5. No, 5 is in the common pathway. So PT and PTT would both be up. 7 is the prothrombin time. Factor 2 is in the common pathway. That would make PT go up. Are you kidding me? Well, factor 13 doesn't elevate the PT or PTT. Factor 13 is not in the clotting cascade. Are you kidding me? This is as simple as just saying that this has to be factors 8, 9, 11, and 12? Yes, it's that simple. A patient with hemophilia, 10%. Does 10% seem like a lot or a little to you? Seems like a little to me, but not in this case. It turns out that 10% is actually plenty to undergo. 10%? I'm glad these people are not adjusting my salary. 10% is enough? Yeah. I don't believe it. You don't have to believe it. It's just the way it is. 10% is enough to do a clotting, an exchange, a tooth exchange. A patient's with AFib and has an INR of 5 because they shouldn't have been on warfarin anyway. But let's say it's a metal valve. Metal valves and mitral stenosis. Metal valves and mitral stenosis, which is the only indication for warfarin with AFib. Well, metal valves, particularly some of them, routinely need an INR that is 3.5 to 4.5. Well, prothrombin complex concentrate does reverse warfarin, but that's only if somebody's bleeding. This person's not bleeding. Fresh frozen plasma, please refer to previous discussion. You have to blood type it. You have to keep all that extra volume. You have to store it somewhere, keep it cold. Vitamin K, well, we can give the person vitamin K, but the issue here with this is that with vitamin K, yes, you bring them all the way back to normal and you'll never get them back up. People with metal valves routinely have an INR of 2.5, 3.5. So 5 is just a little bit outside the normal range. It's not that big a deal. The patient needs surgery and has AFib, and the warfarin's been stopped for 3 days, and the INR is 1.4. Can you operate on 1.4? Can you operate with 1.4? The answer is yes, you can operate with 1.4, and the cutoff is 1.5. You can operate with 1.4 because the cutoff for when it's safe is 1.5. So, ready? Now, you may say, hey, but in my residency, man, I saw all sorts of procedures getting canceled for INRs of 1.3 and 1.4. And I understand that. I saw people steal things once. It wasn't the right thing to do, but people do it sometimes. So, as an alcoholic with portal hypertension, ascites from cirrhosis, and the PT is markedly elevated. Okay, that's routine, right? But is the person bleeding? 90,000 platelets. Alcoholic, ascites from cirrhosis, a PT is elevated. But, I need a surgical procedure. Can I do surgery with 90,000 platelets? And the answer is yes. We'd like 100,000 for brain surgery, for neurosurgery, 100,000 for brain surgery, for neurosurgery, but for most other surgeries, anything above 50,000, there's no more hemostasis at 70,000 than there is at 50,000, than there is 120,000. But the INR is markedly elevated. The PT is markedly elevated. So because the prothrombin is elevated, you should be giving this person fresh frozen plasma to reverse the prothrombin time, to fix the prothrombin time with fresh frozen plasma. Why not prothrombin complex concentrate? Because prothrombin complex concentrate is specifically for people, prothrombin complex concentrate is specifically for people who are on warfarin, Coumadin, to reverse the inhibition of factors 2, 7, 9, and 10. And some of it also has protein CNS. Remember, protein CNS, the anticoagulants, are also vitamin K dependent. Person has atrial fibrillation for 1 day. 1 day. And the point is, you should not be anticoagulating people for 1 day of AFib. This is hard for people to understand because you've seen people do it. Just because you've seen them do it doesn't make it right. Just because you've seen them do it doesn't make it right. You would anticoagulate for chronic atrial fibrillation. Chronic means more than 2 days. Now, if you don't know the duration, you assume it's more than 2 days, but this question specifically says 1 day, no anticoagulation. Are you going to commit someone to a lifetime of warfarin or a NOAC, apixaban, edoxaban, rivaroxaban for 1 day of AFib? Are you out of your mind? The other thing is here, did we say that there's a CHADS of 2 or more? CHADS VASC of 2 or more? We didn't. So, number one, we didn't say anything. Now, the answer could be nothing or nothing until echo is done, but the other point is this. IV heparin for AFib is not right. IV heparin for AFib is never right, just for AFib. First of all, if you felt so compelled to anticoagulate right away, you could use a NOAC, which is therapeutic right away. Bridging with IV heparin or low molecular weight heparin is dangerous. Next, so low molecular weight heparin and warfarin is dangerous, bridging. Warfarin or dabigatran, first of all, it has to be chronic and a CHADS or CHADS VASC of 2 or more. The patient's admitted for syncope. There's 200,000 platelets on day 1, and now all of a sudden, I was just minding my own business, and all of a sudden, my platelets became 5,000. What are you doing? 5,000 platelets all of a sudden, and I don't have TTP. I don't have HUS. I didn't have anything that happened. Nothing happened. All of a sudden, I'm just... First thing to do is be sure it's not an artifact, because artifacts can be first. Exclude it. Platelets get clumpy, baby. Now, which of these is not HABO type? We said fresh frozen plasma is. Platelets, packed cells. Well, packed cells, of course they are. Platelets is confusing. Platelets don't always have to be ABO compatible, but they last longer if they are. They last longer if they are. So if you ABO type them, you're more likely to have the platelets not drop their levels. But sometimes platelets are cross-typed, blood-typed, because there's some reaction of antibodies against platelets. So platelets sometimes are blood-typed, sometimes they're not. They last longer. So in people, for instance, who have aplastic anemia or leukemia, bone marrow transplant, and they need platelets twice a week and 3 times a week, and aplastic anemia, they might need it for months, they should be ABO typed. For a person who just needs it once or twice, no. Don't have to. But prothrombin complex concentrate, that never needs to be blood typed. And the answer is the same to this question. What's stored at room temperature? Fresh frozen plasma needs to be frozen, doesn't it? But PCC can be done at room temperature. Ew! What is this black nasty stuff? Ugh! Patient with melena on dabigatran. What do I do about the melena? Fresh frozen plasma. PCC, idarucizumab, cryoprecipitate. Cryoprecipitate is never first for anything. Cryoprecipitate is basically giving fibrinogen. Cryoprecipitate is basically given fibrinogen. So cryoprecipitate is when I sometimes give fresh frozen plasma and I have galloping away DIC. So this question is saying what reverses dabigatran, and idarucizumab reverses dabigatran or dabigatran, however you want to place the emphases. Now, a 69-year-old woman is admitted for a pulmonary embolus a couple days ago and started on heparin, and the 4th day the labs showed the platelets have started to plummet down. The platelets have started to drop. Now, the most accurate test for heparin-induced thrombocytopenia, is platelet factor 4 antibodies or serotonin release assay. Platelet factor 4 antibodies or serotonin release assay. We generally don't have to do that, platelet factor 4 antibodies or serotonin release assay, unless it's unclear. In this case, though, it's a paradox. What's the most accurate? Platelet factor 4 antibodies, serotonin release. What will I do? Stop the heparin. Stop the heparin. Stop the heparin. Much more common, of course, with IV unfractionated heparin. Now, heparin-induced thrombocytopenia does not make you bleed. Heparin-induced thrombocytopenia makes you clot. And you do get arterial thrombosis. You can get arterial thrombosis. You do get arterial thrombosis. You can get arterial thrombosis, but you get venous thrombosis 3 to 4 times more. Venous thrombosis is 3 to 4 times more. What do you do next? You stop the heparin. What do you use as an alternative anticoagulant? What is the alternative anticoagulant for the PE? Now, if you said argatroban, I forgive you, because argatroban and hyaridin, had been used. But if both of them are in the same choice, you say fondaparinux. Fondaparinux, a factor 10A inhibitor that does not cross-react with heparin. And the only time to say argatroban is if fondaparinux is not in the answer. The only time to say argatroban is if fondaparinux is not the answer. Argatroban both causes more bleeding as a direct-acting thrombin inhibitor. Argatroban also needs Q2 hours PTTs. Fondaparinux is just injected. No problem. Platelet factor 4. I didn't say I was going to wait for this. Serotonin release. It is the most accurate. What's the most accurate? Platelet factor 4, serotonin release. What am I going to do? I'm not going to wait for that. I'm going to switch to fondaparinux. A 27-year-old woman who's evaluated for a coagulopathy and has become pregnant. She's had a DVT. She's had 2 spontaneous abortions. And what will the testing reveal? Ooh, spontaneous abortions? 2 spontaneous abortions. 1 second trimester spontaneous abortion. 2 first trimester spontaneous abortions. You should go looking for a lupus anticoagulant or anticardiolipin antibodies, and the group name between lupus anticoagulant and anticardiolipin antibodies are 2 types of antiphospholipid syndromes. And what do antiphospholipid syndromes give you? Antiphospholipid syndromes will increase your PTT. Increase your PTT. What do you do for the next pregnancy? Aspirin and heparin during the pregnancy. Aspirin, heparin in the pregnancy. 36-year-old woman with severe headache and left-sided weakness and livido-reticularis. Fishnet stockings. I'm not wearing fishnet stockings. Those are some nice fishnets to wearing. I'm not wearing fishnets. And I'm only on, livido-reticularis denies increased bleeding on oral contraceptive pills. And, let's see here. I have an elevated PTT. Normal PT, and elevated platelet count. False positive VDRL. False positive VDRL. So what have I got? I have, a lupus anticoagulant, antiphospholipid syndrome, a lupus anticoagulant, antiphospholipid syndrome. It's a lupus anticoagulant, not the oral contraceptives, lupus anticoagulant, antiphospholipid. Why? Because of false positive VDRL. False positive VDRL. Factor 5 Leiden doesn't change the PT or the PTT. Antiphospholipid, false positive, VDRL, elevated PTT. Now, the initial test is a mixing study because you're looking to see a factor deficiency or inhibitor, an inhibitor deficiency, inhibitor deficiency, inhibitor deficiency. What's the most accurate test for a lupus anticoagulant? The most accurate test for a lupus anticoagulant, it fails to correct on mixing, is the Russell Viper venom test. Viper is in the snake? Russell Viper? Yes, for a lupus anticoagulant. Now, for the next pregnancy, what are we going to do for the next pregnancy? For a lupus anticoagulant, anticardiolipin antibody. For the next pregnancy, is heparin safe in pregnancy? Yes, it is. Heparin is safe in pregnancy. Warfarin is not safe in the first trimester. Heparin is always safe. 27-year-old woman who's got a pulmonary embolus and a DVT at the lower extremity. She's been treated with 6 months of warfarin. There's no history of cancer or recent surgery. What's the most common cause? Well, this is basically just saying what's the most common cause of hypercoagulable states. and the most common cause of hypercoagulable states. Antithrombin is not as common. Protein CNS are even less common. Lupus anticoagulant is not as common as factor V Leiden mutation. Now, what difference does it matter if somebody has a factor V Leiden mutation? When you were treating with warfarin, you went to an INR of 2 to 3. When you were treating with a warfarin or a NOAC, you went to 6 months of therapy. What difference does it make if it's protein C or protein S? When you were treating with warfarin, it was the same intensity of warfarin, INR of 2 to 3. When you're treating with antithrombin, same intensity of warfarin, INR of 2 to 3. So what difference does it make if it's factor V Leiden mutation? On the first clot, no difference. But on recurrent clots, you may go lifelong. The therapy, possible because it's recurrent. Low molecular weight heparin and recurrent. So how do you recognize protein C deficiency? Protein C deficiency is recognized by people who went on warfarin and developed, this is the easy one because it's 40 years old, and developed skin necrosis because protein C is an anticoagulant. Protein C is an anticoagulant. And by the way, this thing about using it for Lovenox, low molecular weight heparin, for hypercoagulable states, they will not ask you to choose between that at the initial therapy and a NOAC because both of them can be considered acceptable in both cancer-related clots and hypercoagulable states and thrombophilia. So it's unreasonable for them to ask you at this time to choose between enoxaparin and a NOAC, apixaban, edoxaban, rivaroxaban, and dabigatran, and enoxaparin on these clots. Now, how do you recognize antithrombin? Antithrombin is how heparin works. Heparin and low molecular weight heparin, Lovenox, enoxaparin, work through potentiating antithrombin. So if you don't have antithrombin, your heparin will not work. So you're resistant to heparin effect. How will you tell if there's antithrombin deficiency if you go straight to a NOAC and never use heparin? You won't. So summarizing these questions, a person that has a DVT, even unprovoked, there's no point in checking for thrombophilias, protein C, protein S, factor V Leiden, because it's the same duration of therapy, 6 months. So you don't check for them, because even if they're there, they don't change therapy. Well, there's a different question. Which of them is most likely to recur? And the answers for that are antiphospholipid syndromes and antithrombin deficiency, antiphospholipid syndromes most commonly. Should you get lifelong anticoagulation with one clot? There's no answer to that question. The answer is generally no. There's no answer to that question. Even an antiphospholipid, they have to ask you, in our boards, they have to ask you an answerable question. And the answerable question is which is most likely to recur? That's an answerable question. And the answer is antiphospholipid syndrome is most likely to recur. See you in the next section.